actually part of a four-part series on boosting your bottom line, the Bags of Money series. And today's webinar will focus on picking up your money. My name is Boris Volgorin, and I'm with CTAC, the Community Technical Assistance Center of New York. And I am very excited and happy to say that we are joined today by Lisa Clark from the New York State Office of Mental Health, who will be presenting through the webinar today. And a lot of you probably know Lisa. Lisa has actually worked with a number of mental health clinics in particular throughout the state in helping clinics become more financially stable and healthy. And so today, Lisa will share some of her tips and knowledge with all of you. So today's agenda will, of course, we'll go through the introductions as we kind of did already. We'll then focus on what's the problem and how to fix it, of course, and we'll hopefully we'll have time for some questions and answers. But before we jump into the presentation, we actually wanted to ask you, the participants today, some questions. So we have a few polling questions that we will present. If you don't mind answering, that would be great. So we'll just pause for a minute or so. So please answer the questions. We'll give it another 30 seconds or so to give folks a chance to answer the questions, and then we'll get right into the webinar presentation. All right, some actually housekeeping rules just before we jump in. So first, thank you for those of you who answered the questions. Really appreciate it. Housekeeping rules, as I mentioned, at the end of the presentation will be, we'll stop and we'll take the questions, but please, throughout the presentation, use the chat box to chat your questions in throughout the presentation as they occur, and at the end, we'll try to get to as many of those as possible. These presentations will be available on the CTAC website, as well as the recording of this presentation as well. So with that, with no further ado, I will transfer this over to Lisa to start the presentation.
Thank you, Boris. Hopefully everyone else is at least half as excited as you are that I'm here doing this today. So the reason we kind of have, I don't know how many of you have done the prior webinars. We did revenue maximization strategies, and then we did a boosting your bottom line. But the reason that we've put this series together, and I always love this slide, credit goes to Jim Montfort at CCSI for this, but I think it's really important to look at this, that in 2013, 56% of clinic providers were losing money. So, that's why we're doing this, trying to give you strategies and tips to improve your bottom line. Because in this slide, as you can see, just increasing revenue by 15% makes a huge difference. That 15% increase means that now only 35% are losing money, still not a good thing, but we have gone from 44% to 65% of people now who are healthy. So before you can fix this, you have to identify what's the problem. Why are providers losing money? I kind of developed this expertise. I have to credit a former colleague of mine. She knew that I had been doing some of the the fiscal viability stuff a few years ago where we did like a statewide analysis of those things that you saw previously, how many providers were distressed, concerned, healthy. So she knew I'd been working on that project, and she just couldn't figure out. She started looking at her numbers. She was a clinic director, so she likes to say that she's, not a money person, not a data person. She's a social worker. But she started to look at her docs, and she's like, why is it that I pay the most money for my doctors and they are bringing in less money than my clinicians? Like, can you look at this and help me? So she sent me her actual claims data, and when I looked at the claims and I could see what it was she was billing for and what she was actually getting paid, there were some key things that jumped out at me. So normally when we think of what's the problem, the most common reasons that you hear for why clinics are losing money are, commercial insurance rates, they're not paying enough, OMH, the Medicaid rates are too low, which is seriously not the deal. New York State has significantly higher rates than most other states in the country. Payer mix, which, that can be an issue in some places. Productivity, workforce costs. My parents were too tough on me when I was a kid. But what we really found once I started looking at her claims, we were able to identify some more concrete reasons. There were coding issues, simple things like a 90792, and then I looked at this on a statewide basis. We did an aggregate look at that one code, which is an initial assessment with medical services. In order the only staff that can provide that service are a doctor or a psych nurse practitioner. So whenever you use a 90792, there should be a modifier added. I saw that 52% of clinic providers were not adding that modifier, which meant they were losing 45% of the money that they could have collected on that one service. There's also a general lack of understanding of what activities you can get paid for. Some of that has to do, not a lot of folks are, have the inclination to sit down and read our 599 guidance, which you can find on the OMH website. And there's lots of information in there, but it's many pages long and it takes a while to kind of go through. So, what we're doing here is hitting the high points of the areas that are kind of most commonly missed. Day-to-day processes fail to maximize revenue. That goes back to what are the reimbursable activities. And even after doing all of this and giving these other webinars, as I've gone out and met with additional providers and I've said, how many people have, participated or watched one of these webinars, and I see hands go up, and then I ask, have you taken action as a result of that? And the hands go back down, and I'm like, that just drives me crazy. So the key to any of this is you have to actually put it into action. So we can share all the tips here through CTAC, but you have to clearly identify a person and make sure that you're checking the tips and using the things that are here. But the thing that I got most excited about when I looked at those claims, and we saw that these were the things, and we could identify concrete, specific things that didn't have to do with commercial insurance or payer mix. These were things that you can actually, the clinic provider themselves, can make these changes and, as I like to say, pick up the bags of money. So that's, I get a little excitable about these things because it's seriously, it's like that easy. So here in the prior webinars, these were like the tools that we shared with you and the different strategies, and you can go back. If you missed those webinars and you want the information, ctacny.org. On their website, they have a great search tool for their assorted trainings, and if you put in, probably the easiest way is if you put in presenter and you put my name in, Lisa Clark, it'll pull up two webinars, the revenue maximization and boosting your bottom line. So you can kind of go back and re-review what the specifics were of these tools. So now we get to, are you using these tools and fixing the problem, Or are you like my son, who, whenever I ask him, have you done X, Y, or Z yet, what he likes to tell me is, I'm working on it. Which, you know, obviously is a little maddening, and the same thing, like I said, when I go out and now follow up with providers and the hands go down. That's kind of the equivalent of I'm working on it. So you don't accomplish too much in this phase. And so the goal for today is to provide even more concrete checklists, and at the end of this, there's going to be a cheat sheet of specific tips for you to follow that I want you to use so that you can kind of get past this and hopefully get to that 15% revenue increase. And as we can see, if you use this and then you actually are the one who's working on it, this is probably a little super optimistic, but we're good here. A little bit more about how we got here. You know, the times they are changing. Once upon a time, back in the day, we all remember we didn't have to worry about business practices and all of these fiscal strategies. Clinics just focused on delivering clinical services. If you had poor business practices, way back then, we had this lovely little add-on payment for Medicaid called COPS, a COPS payment. And so if you were losing a lot of money, you could basically let OMH know, and then they would increase your COPS payment. And these got really very high, too high. And we basically incentivized you to have poor business practices. Not that we encouraged it, but there was, you know, we built in a safety valve for you. Then we came up and the Fed said, yeah, veto the COPS funding. That's not something we want to continue to, you know, support. That as part of the loss of the COPS funding, we moved into the clinic redesign phase and the shift to APGs. So the services then moved into the ambulatory patient groups. And as a result of all of that, we, you know, the yanking out of the high supplemental COPS rates and moving into this new APG billing system was really a challenge. I mean, new things are hard to adapt to, and the result of that were some significant, you know, fiscal viability problems for a lot of providers. So today, as a result of those viability problems, there's a much higher focus on business practices within clinics. So while you're often, the director of the clinic is often your, you know, a social worker and you didn't go to business school, we kind of are in an era where we have to find a balance of clinical and business best practices. Then as we move into the future, and a lot of times I hear providers actually saying they're looking forward to getting to this point. I know all of you may not agree with that, but when we get to value-based payments, now you're looking at payments are based on outcome measures. So now we're kind of walk side by side, good clinical practices and good business practices. You have to have good business practices in order to stay in business as a clinic and survive and be viable. But in the future, your reimbursement is actually going, your solid, strong clinical practices will be, you know, are going to pay off for you financially because those value-based payments are going to be based upon that. So how do we get there? And just in terms of value-based payments, so that's all the more reason right now to kind of up your game in terms of analytics and data collection, analysis. When you're hiring new staff for certain positions, you want people who have these skill sets if you don't have them naturally yourself. So keep that in mind. It's not just like data entry stuff anymore. Accountability, who is looking at this? Don't assume, everyone kind of assumes. So this particular presentation is targeted more for our middle managers, the CFOs, clinic directors, the person overseeing all of the billing. Find out amongst yourselves, and maybe more than one, but identify who is the person that is going to follow up on these tips that that you're going to see today and hear about. Identify that person, share the results of this information amongst yourselves and be sure that this money is getting picked up, because this is the easiest money that you're going to get. So what are you looking at? Look at the actual claims. So I'm not familiar with the intricacies of the different reporting systems that you have available within your billing software, but you guys should be, and you need to know what are the specific variables that you want to track. What are the codes and services where you're most likely to be leaving bags of money on the floor? So we're going to identify those, and then the other thing you want to look at is not only are you providing those services and billing for those services, but are you being paid properly for them? Are you getting all the money that you should be? And where are you going to be looking for this? So we're introducing this. A lot of folks, you're familiar with productivity. You may have productivity reports within your agency. I want to kind of take that one step further and not just the productivity in and of itself, and I think each agency may, look at different things in terms of how you determine what's in productivity. And in one of the future webinars, one of those will be on productivity, and Boris and or Dave Wozniak are going to be kind of looking at that in more depth and detail and giving you some tips on how to track that. But what I'd like you to start thinking about is doing a service distribution report. Not just are they productive with their time, but what exactly is being delivered. Because there's certain services that they might be doing, but you're not seeing it on a productivity report, or they're not submitting claims for those particular services, and those are all worth, that's money on the floor. If you're picking up background noise, I'm just going to share with you today, it's like our health fair, and so outside this conference room, the halls are a little noisy, so hopefully you won't be distracted by that, but there's not much I can do. All right. So where's the easy money? And back to the example that I started with, most of the money really, this is your staff that you're paying the highest salaries to, and these are the ones where there's a little extra step usually in how you're getting reimbursed for these. If you use the tips in here, you could make as much as 45, so that one code that we already looked at briefly, that's a 45% difference. Some of these you'll see you could be leaving as much as 87% of the money on the floor for work that your docs and your psych nurse practitioners are doing. Interesting, I left a note in here of something I wanted to put in the presentation. We'll just skip that. The most common reasons in here are failure to add a modifier or failure to use a psychiatric add-on code. So initial assessments. You can get paid 45%, that 45% higher rate for using that physician modifier. So for upstate providers, that's an extra $66, downstate $73, counties $92. So I want you to look at those claims reports specifically and count. So before I go out to a clinic provider, if there's someone having some significant issues, I can have been sent out to work one-on-one with providers. I know you would all like to volunteer to have me come and visit you. That's not an option. It's usually a recommendation by fiscal folks here or the field offices. But before I go out, I have all their claims pulled in. I filter the claims by certain codes. So those are the codes that I'm sharing here. And I'll look and see how many 90791s are being done by the docs and the psych nurse practitioners. What your real goal here is for zero. The easiest thing is, what you want is your doctors and psych nurse practitioners to be doing, instead of a 90791, you want them to do 90792s. That's an initial assessment with medical. If you always have them do that, so procedurally, this simplifies it. It reduces the chances of leaving the money on the floor. You can automatically, whenever they do a 90792, have your systems programmed to automatically add the appropriate modifier based on whether they're a doc or a psych nurse practitioner, put that in there, and then you're always guaranteed that you're going to collect that extra 45%. Another reason for you to do the 90792 for the docs over the 90791 is that while OMH says that you can be reimbursed for up to 3 initial assessments per individual, very often we hear that Medicaid managed care plans don't necessarily, and they're not required to pay for all 3 initial assessments. But what I've heard is that the general practice is that they will reimburse for 1 90791 and 1 90792. So you want to make sure that you're doing that. The next thing you want to do is when you now look at your claims and filter through and look for the specific code 90792. Now look at what you're being reimbursed for it. Check the rate you're being paid. Don't assume that you're being paid correctly. If you have, so what I've put here for upstate, downstate county, those are the general rates if you have the QI add-on. If you're not sure if you have that or not, you can look on the OMH website and go check there's a base rate sheet in there that you can check. So confirm that's being paid. If you're not being paid dollar amounts close to what these are, then you're probably missing a modifier on that code. So have that person, whoever's identifying this, look at that and get that addressed. The other thing I want you to do is when you look at your claims, look and search, filter, however your reporting mechanism allows you to do this, for the E&M codes 99201 through 99205. These are the evaluation and management codes that doctors and psych nurse practitioners use for new patients. I would recommend whenever you have a new patient, generally speaking, the doc should be meeting with them for that initial visit for a minimum of 45 minutes to really spend the proper time to clinically get to know that person, their history, all of the things that they need to be doing for good clinical care. That should easily take 45 minutes. Oftentimes I hear from folks, especially children's clinics, that your psychiatrists, when they have that initial visit, are spending an hour or more even. So if they're just submitting a 99201 through a 99205, you're leaving tons of money on the floor. So encourage, again, use that standard practice and procedure for that first assessment. It has to be a minimum of 45 minutes in time, but if that's your standard practice, use that 90792. And the only time you would want to use those other E&M codes is if the visit doesn't meet that 45-minute minimum. Then we want to look, besides the assessments, how much time are your docs, psych nurse practitioners spending on appointments? Are they spending 30 minutes or more? So this happens a lot. And if you look here at the, let's see, Nope. All right, so if we look here at this column, the psychotropic medication treatment line, if you only submit that E&M code without using an add-on, that yellow row is the amount of money that you're going to get paid. So if you're spending 30 minutes on a visit, use this 90833 add-on. Here's how much additional money that you're going to make on these on the second row. And then if it's 45 minutes or longer, use the 90836. So if we go over here, back to that wanting to increase your overall revenue by 15%. You remember I told you it could go anywhere from 45 to 87% If your doc is spending 45 minutes and you're not adding on a 90836, you're leaving as much as 87% of the rate that you should have collected. This is the hidden money up here behind the chair. Where do you find it? That's just sitting there that you should have collected for that service. So filter your claims. Look, do you have 90833s? Do you have 90836s that have been submitted? Now, because those are add-on codes, you're doing those. You should also see like the 99212 through the 99215. There should be an E&M code, and then that's an add-on for the amount of time that that person spent with the individual for psychotherapy. And you can go back and kind of look at the earlier webinars, kind of explain in more detail that New York has the ability for Medicaid to flex the rules. So this is what I was just saying, you know, what are you looking for? Where are you finding this money? Look for these codes if you know your docs are spending that much time with people. So some of you may commonly just do 15-minute visits, that's fine, but you know somewhere along the way they're doing 30 and 45-minute visits. I always like to put this in here as kind of this disclaimer that the rules are different for Medicaid and Medicare. So review this, go back to the earlier presentations on this, send me an email if you have questions on it. But the rules are different for Medicare. Like I said, I don't want to get into the nitty-gritty of that because this is really looking at what specific codes are being used. So, good news is there's even more money. Where is this? Crisis intervention. So these, when we go and I do in person, the things I ask, is your clinic do walk-in crisis services? If you are, you definitely, and I've gone and there are clinic providers who provide walk-in crisis services, and I look at their claims, and if I'm looking for an H2011 and I see none, that's a problem. If you're doing crisis, everyone has crisis. There's no way you work with people who are mentally ill and you're not providing crisis intervention services at some point. Walk-ins, though, definitely. And for walk-ins, if you just have a walk-in clinic service, crisis services, the person does not even have to be admitted to your clinic in order for you to be reimbursed for a crisis intervention brief. You're allowed up to 3 pre-admission visits that you can get reimbursed for. If for some reason you have a frequent flyer who's only coming in for crisis services, you wouldn't be able to continue to get reimbursed for that beyond 3 visits, but you should really be, if that's the case, the person obviously needs they need to be admitted to the clinic and get regular clinical interventions. So are your clinicians, and this goes back to that service distribution report, I want you to look at this by staff person. So you want to see, all of your staff at some point or another are doing crisis intervention services. Look and see by staff if you see these codes H2011. Make sure your staff knows that they can get reimbursed if they spend 15 minutes by phone. That's a reimbursable service. How much more could you be making if you're underutilizing these crisis codes? So an H2011, here we have, $57, $63, $79. That's for 15-minute units. I mean, that's decent money. The complex, that has to be an hour with 2 staff people. Happens less often, but that's good money we have here, $342 up to $477. And the per diem, which is very rare, and I'm sure quite memorable when and if it should occur, of 3 hours or more face-to-face time by 2 staff, and you want to definitely be sure you're being reimbursed. So look for these specific codes in your claims, the H2011. So the expectation here is that all of your staff at different points in time should have H2011s in their claims. It might not be every month, but fairly regularly somebody's doing some type of crisis intervention. And if it's done by phone, if a parent calls up and a child's about to get kicked out of school, or if it's an adult and they're about to lose their housing, any of those things are potentially crisis intervention, and you could provide a whole list of other examples. Look, make sure you're getting reimbursed. How many S-9484s do you have in your claims? Certainly less frequent, but may occasionally happen, and pretty rare, but the S-9485s. Another seriously underutilized service is the complex care management, the 90882. This is one of those things, you know, providers are always saying, you know, my staff spends all this time on phone and follow up to things, and it's not reimbursable. Well, it may very well be reimbursable under a lot of instances under complex care management. And it used to be 15-minute units, and we actually changed that, so now it's 5-minute units of time up to 4 units. So if your staff is spending 5 minutes or more coordinating care in response to some potentially destabilizing situation with one of the individuals you're serving, they can bill this 90882. Make sure they're, you know, documenting it in the initial note. If there was a crisis intervention, very often in response to a crisis intervention, that you're going to be able to use complex care management. Complex care management, however, does not only have to rise to the level of a response to an actual crisis. Things like, is there a potential medication interaction, suspected noncompliance. A lot of times I hear docs and your psych nurse practitioners are making phone calls on things like this. It can't be used as a general course of business for day-to-day routine stuff, but you can look at, I recommend you look at the 599 FAQs that we have to kind of get examples of these. And how much money, how much additional revenue can you be making here? I mean, 5 minutes of time pays anywhere from $14 up to $19 for a county. If you use the full 20 minutes, anywhere from 55 to 76. And that can be by phone. That's just the general collateral contacts that we all know are really, the value of them for good clinical integration and coordination of care is really important. So you just kind of have to put that at the forefront of your staff's brain, so to speak, and make sure they're remembering to use these. So one of the things I always like to look at, too, is comparing a unit of something. So if you look at a 15-minute unit of complex care management, which would really be 3 5-minute units, and you were to look at if your clinician spent the same 15 minutes of time delivering, so a 90832 is really a 30-minute visit, but if we're looking at it unit by unit, I mean, you can see that the complex care management rates are really close to the actual staff time spent delivering that face-to-face psychotherapy service. So the point there being, these can add up to a lot of money. Make sure you're using them. Filter by these, look at them by staff person. Have the expectation that all of your staff should have 90882s that you're getting reimbursed for. In one of your staff meetings, do a presentation on what constitutes complex care management. The 599 guidance documents have a really nice section of FAQs on different ways, things that are reimbursable under complex care and things that are not. Go through those, give a presentation on them, have staff ask questions or give their own examples, and include this as part of that individual service delivery report and review it with your staff during supervision. Psychotherapy. Now, this is another one. It can be used for children's providers or those serving adults. It's more commonly found with kids. Kids can take a lot of time. They're often accompanied by parents to visits. This is especially big money if you're doctor or psych nurse practitioner is spending an hour or more with a child and a parent is present there for part of the appointment, they don't have to be in the entire appointment, nor does the child have to be present for the entire appointment, but the child needs to be present for at least half the appointment. You don't want to miss these. So for a clinician, here we have the 176 down to the 245, and you can see that for the doc and the psych nurse practitioner, these are the amounts. So if you're going to look at your claims for the 90847, you need to also make sure that you're checking how much you're being paid, and that because if you see under a doc or a psych nurse practitioner that you were reimbursed $176, then you know that the modifier wasn't added. So that's something that will need to be addressed. So look at that code, how often is it happening? Remind your staff. A lot of times it's people just get used to certain codes that they use all the time, the 90832, the 90834. Some providers have their systems, I think, programmed so the length of service automatically kind of populates the code that's being used. So, and in others it's different. Some of you still do kind of manual submissions to your billing staff. Another thing to remember is if your doctor or psych nurse practitioner even joins a psychotherapy session for a minimum of 15 minutes. Now this could be your 90847 or it could be any of your psychotherapy sessions. If they come in and a clinician feels there's something, they want to kind of get some input, or there's cause to have them kind of jump in on the session, and they're in there for 15 minutes or more, remind your staff to note that within the progress note, so it can be the clinician's note that this, the doctor joined the session, make sure the modifier is added to that session, and then your doc or psych nurse practitioner doesn't have to write a separate note, they just need to co-sign the clinical note that was written by the clinician for that. All right, so here's our best of the rest money tips. If your clinic or your satellite clinics are open weekdays before 8 a.m. or after 6 p.m. on weekdays, or if you have any weekend times, look at your claims, see if you can find 99051. If you have no 99051s, you have a problem. So there's a bag of money, figure out why it's not being, identified, fix that, and you're going to increase, you're adding 7.6% to the base rate for that service. For language other than English, some of you regularly provide you have bilingual staff or frequently, commonly providing services in another language. Make sure, look on your claims for the U4 modifier. That shows that's being accounted for, that increases the rate you're being paid by 10%. You can kind of look at that. Obviously, if you have staff that's not bilingual, there's not much use in kind of looking there to see if the modifier is being added. Although it could be if they happen to bring somebody else into the session. It can't be a family member. It would have to be a staff person of the clinic to do translation. But for your bilingual staff that deliver services regularly, make sure that the U4 modifier is in there. And I always like to mention off-site services. Those are paid at 150% of the rate. For adults, that can only be done for crisis services, although now, I'm going to put an asterisk next to that because now it can be done through off-site licensed behavioral health professionals, LBHPs, for Medicaid managed care. In order to know if any of your staff, if you think they're doing off-site services, you want to know, or you want to confirm that you're being paid properly for that, you can look at, there's different rate codes that are used for the off-site services, and if you look at our 599 guidance document, you can check out page 27 of our guidance document to make sure that you're getting reimbursement for that. So if you, back to that is not my favorite slide. My favorite slide is the one that shows that the 65% of the clinic providers are healthy. So I'm not going to flip all the way back to the beginning on that. But the other thing I wanted to show, and this will be loaded up on the CTAC website for you to access, but here is a summary tip sheet, cheat sheet, whatever you want to call it, there's kind of two versions. The longest one is for your docs and your NPPs. When you're done with this, I want you guys to name the person who is going to follow up on this, specifically identify who that person is. You can take these tips and you can move kind of these, these are all the things that we just covered, but it's like point for point for point, mapped out as clearly and concretely as they possibly can be to follow up on. And, it says, what is the expectation? Are you kind of expecting that you should be seeing these? How often? Up here, obviously I can't be completely prescriptive. These are tips and strategies for you to use. If you guys choose to use 99201 through 99205 for your new patients and not do the 90792s, you're free to do that. But these are strategies that if you adapt into your everyday process, you're going to bring in more money and increase that revenue, hopefully by at least that 15%. That will push you up into the green and healthy range. While there are, all right, there's another page which somehow didn't translate here. There's another tip sheet for clinicians that's not, hold on, let me see if it's up here. Aha, all right. For clinicians, this isn't as long as the other. There's not as many find the money, so to speak, tips for the clinicians. Their reimbursement is a lot more straightforward. There's not as much kind of bags of money left on the floor for them. But this is another thing. I encourage folks in staff meetings, remind staff when to use the different codes. Explain to them, share with them. Be really transparent when it comes to this fiscal stuff. You help get the buy-in and support of your staff instead of kind of just, harping, that's not a great word, but that's probably how it's interpreted, harping at folks that they need to increase their productivity. Make sure they understand why they need to increase their productivity, how important it is, what are the fiscal implications, the viability challenges. Do things like give a presentation on complex care management. In supervision, share with them what the service distribution reports, kind of acknowledge and recognize when they make improvements. And someone who never billed for complex care management or never, billed for a crisis intervention, you see this now on there, you're bringing in more money, make sure that you're giving the reinforcement for that. So we're going to go back and we're going to take any questions. If folks have questions and you want to type those in, I think, Boris, are you going to?
Yeah, I'm back. So thank you very much, Lisa. This was wonderful and excellent, very informative. So we did have some questions that have come in. So let me just, read those off, and we'll take it from there. So our first question came in and says, can an Article 31 clinic bill for CPT code 99051, which is the evening weekend charge, for legal holidays?
For legal holidays?
Yes. I guess if a clinic is open on a legal holiday, can you use that as part of the evening weekend?
That's probably a really excellent question, but I don't recall ever seeing anything that speaks specifically to that, so I'm actually going to bounce that one to you, Boris. Do you know the answer to that?
I don't know either, but that is a great question. So I think what we're going to need to do is take it back and get back to folks about that and see if a clinic is open on a legal holiday, if they could use that code. So that is
my first.
Yep.
My first thought is, because I know certain things like Veterans Day and things like that where the dates change year by year, that if you were to get audited, I would just have some concerns about the ability to match a holiday schedule versus the regular hours of operation of the clinic. So if that's like a weekday and it shows that your clinic's open on weekdays.
Right. But no, right. So that'll be probably need some good documentation and make sure. But I think it's something we should take back. I think it's a good question.
Yes.
And if folks are doing that, that's great. Another question, just as a clarification about 90792. You were not referring to it as a modifier. You were, I think, what you're saying when you say 90792, that's the CPT code, different than a modifier, right? So there was just a clarifying question, I guess. Is that accurate?
Correct. So the 90792 is the actual CPT code that you use.
Right.
The reason I was recommending it is because you can automatically program your system to add the appropriate modifier. 90792 can only be performed by a doctor or psych nurse practitioner. So
Great.
That's where you automatically add the modifier into your system to make sure that you're not one of the 52% of providers who didn't add the modifier and left the money.
So I guess I just want to make sure, when you say add the modifier, you mean just to modify your system, or because 90792 is the CPT code? So again,
90792 is the CPT code.
CPT
so
code.
If you use 90792 by itself, let's see, do we have the, if you only put in a 90792 by itself without adding the modifier, which,
gotcha.
Let's see, hopefully we're not making people queasy.
Busy.
All right. If you only put a 90792 and you don't add the AF or SA modifier, you're going to be losing
money.
60, right. So, right, it's a 90792 and then AF or SA modifier with the 907.
Great. Thank you for clarifying. Another clarifying statement. So when you, I think I can answer this one. When you were referring to county or county was listed, you were referring to the county-run programs. Because there was a question clarifying if Brooklyn, New York City is considered to be downstate or county. I believe it's officially downstate, but county was referred to as a county-operated program. Is that correct, Lisa?
That is completely correct, Boris.
Good. Okay, just wanted to double check. Next question. What are your thoughts about getting, I guess it's MCOs to pay for crisis by phone when we have been denied before? So I guess somebody's experiencing denials from managed care companies when they perform crisis by phone.
So now I am going to, and why did I take that slide out of here? Does anyone know off the top of their heads the email address for the managed care, the OMH managed care? It was on the last webinar PowerPoint.
All right. So what you're saying is the individual should email the OMH box, the info line, and notify the OMH that which company is denying it. Because the bottom line is MCO should be paying for the same services that APGs, and that's in regulations. There shouldn't be a distinction between what managed care pays for and what Medicaid pays for. Right? Is that correct?
Correct.
Right. So if they're denying because they're saying that they don't pay for phone crisis, then that probably would be an inappropriate denial. If there's denial for some other reason, that would need to be looked at. But I think, so we will need to get that. Also, on the chat box, thank you, our CCI colleagues. It looks like it's, is
Boris,
that?
Let me just.
Yeah. Go ahead.
Let me just add one more comment to that, because I want to be clear. I don't ever want to pretend to answer something that I'm not 100% sure about. So if they could send that, and I apologize that I don't have, unless someone actually is about to produce the email address I was looking for. So sometimes Medicaid managed care plans, while they have to reimburse all the codes, they may have a slight variation for certain things, so whether it's reimbursable when provided by phone or not. Of course, I don't know how the plan would know it was provided by phone, because there's nothing on the code when you submit a claim that would be indicative that it was provided by phone.
Gotcha. Yep.
But they could send that to the managed care box to be sure.
Right, and so we got a couple of texts that is giving us that email address. So it's omh-managed-care@omh.ny.gov. It's also in the chat box. So if you have your chat box open, you can see that email address. And so we got it from a couple of folks, one of them being our CCSI partners and others as well. So thank you for that information. Let's move on to the next question. What is the difference? What is the difference from 90792 and 99201-99205 codes?
So the 99201 to 99205 are evaluation and management codes that are used to indicate that you're seeing a new patient. These are codes that are used by the docs and the psych nurse practitioners. The recommendation was that whenever it's a new patient, they should, it's good practice to see them the first initial appointment for 45 minutes or longer. So it's more advantageous to, during that time, provide them with a 90792 with the modifier versus the new patient 99201 versus 99205. Does that clarify it?
I think so. Thank you for that. First, there's a compliment. So the presentation was so useful, learned a lot, and the individual does want to, could you briefly explain the staff well-being issues? So I don't know if...
Of the staff here? I'm not sure what you mean by the staff.
I think the staff of the clinic.
For here at OMH, the struggle is real.
Yes.
As it is, I'm sure, for all of you.
Yes, definitely.
Unfortunately, I'm not sure if they could type in any additional information. I'm not sure what they mean by the staff well-being issues.
Well-being. Yes. Okay. So if they follow
hold
up.
on. Someone just gave me a tip that they think I might have meant was in the charts where the providers were classified as distress, concern, or healthy, that they might have been referencing that. Hold on, let's see if
Maybe.
So that might be what they meant by well-being here. So healthy is close to breaking even and making money. Concerned, I think, was if you're losing between 5% and I think it's like 20%, although that right there looks, and distress is if you're losing more than 20% of your, right, it's not staff well-being.
Potential revenue. Right.
Right, this is a fiscal wellness classification, not the staff.
Right. Gotcha. All right, so hopefully we'll follow up. So I'm just looking at time. We have a minute left. We'll take one more question. We do have 2 more questions for polling we would love for folks to answer. So last question is, what is considered a new patient? For example, if a client gets a routine therapy services but goes to see the MD/NPP for the first time, are they new or existing?
Well, they're new to the doctor. They're seeing them for the first time, so that would be considered new. But if they're a new, so let me like just kind of add a disclaimer to that. If the individual has been enrolled in your clinic, and let's say they've been going to your clinic for an extended period of time, and now they're assigned to a new psychiatrist, while they may be new to that psychiatrist, they're not new to your clinic, so you would not categorize them as a new patient. But the docs are usually pretty well versed in what counts as a new patient versus existing.
Gotcha. Well, thank you for clarifying. And again, thank you, Lisa, for this wonderful presentation. Again, I would ask folks to, answer the 2 poll questions that have come up. We have 3 more presentations in this series, focusing on reporting coming up next as the second one, productivity the third one, and followed up by dashboarding. Please look out for more registration and more information on those. And please join us during those presentations. And again, thank you everybody for joining, and hopefully you'll be able to join us for all of these. And hope everybody has a great the rest of the day. Thank you.